Okay, you want to take your seats, and we'll get started. My name is Scott Beatty, and I am going to moderate this session on myocardial injury and infarction, pathophysiology, prognosis, and treatment. And we've assembled, I think, an excellent panel to give us an insight into what has emerged as a very large clinical issue. I'm going to ask the presenters to speak for about 25 minutes, and we'll have about 15 minutes at the end to answer questions. Our first speaker today is Dr. Giora Landesberg, who's from the Hadassah University in Jerusalem. I've known Dr. Landesberg for a long time, and he is one of the things that's very impressive about Dr. Landesberg. He was the first investigator to show a dose-response relationship between cardiac biomarkers and survival, which has been reproduced many times now, but he was the first. He has a wealth of knowledge. He's been quoted many times. One of his articles is in circulation in 2009, entitled Myocardial Infarction. It's been cited over 400 times. So I looked that up today, Giora, so it's okay. So with no further ado, Dr. Landesberg.
Okay. Well, I should be looking like that. Thank you very much, Scott, for the kind introduction. And I would like to thank the organizers for allowing us to present this topic, perioperative myocardial infarction, injury, and ischemia, actually, pathophysiology. I have no conflict of interest, unfortunately, and nothing to disclose. As you well know, the dominant paradigm about the pathophysiology of myocardial infarction, according to the cardiologist, is that almost all myocardial infarctions are the result of plaque rupture and acute coronary thrombosis. This has been true at least until 10 years ago. So we have stable plaques, we have unstable plaques, and the unstable plaques have much more inflammation and very thin fibrous cap. And once this ruptures, there is a thrombosis, and thrombosis occludes the artery and causes ischemia and later to infarction. What's interesting, though, is that the same pathophysiology is causing both ST elevation and non-ST elevation type myocardial infarction, as you well know. And there is a major difference in therapy, current therapy, between ST elevation and non-ST elevation type myocardial infarction. In ST elevation type myocardial infarction, as you know, patient must be rushed immediately or as soon as possible, to the cath lab to reopen the acutely occluded coronary artery. Whereas in non-ST elevation type myocardial infarction, repeated studies, even recent, have shown that there is no significant benefit for such treatment. So the explanation is, according to the theory, is that in ST elevation type myocardial infarction, there is acute occlusion, sudden occlusion of a major coronary artery. And that's why there is a thick necrosis, transmural necrosis. Whereas in non-ST elevation type myocardial infarction, there is the same plaque rupture and thrombosis, but maybe the thrombosis does not occlude the whole artery. Maybe the artery is not that dominant. Maybe there are collaterals. Maybe. Nevertheless, both myocardial infarctions are infarctions, and both can lead to congestive heart failure and death. As a matter, and the convention is that non-ST elevation type myocardial infarction is a smaller infarction, whereas ST elevation infarction is a larger infarction. Nevertheless, as you can see here, this is only one example. There are many examples. The prognosis in non-ST elevation type myocardial infarction is worse. More mortality in the long run in non-ST elevation type myocardial infarction rather than ST elevation type myocardial infarction. I will not go into the explanation. You can find it in the literature. The another peculiarity is that those studies that have been published in the 1990s, patients with known coronary artery disease were repeatedly catheterized. And the studies, some of them developed myocardial infarction along the road. And the studies showed that the artery, the culprit artery, that caused myocardial infarction in most cases was with stenosis of less than 50%. And 18% was between 50 to 70%. And only 70%, and only 14% was occlusion of more than 70%. So most of the acute myocardial infarctions are actually caused by relatively young and non-occluding plaques. So this is the general information about cardiology or myocardial infarction in general. What do we know about perioperative myocardial infarction? Up until 25, 30 years ago, we knew very little about the pathophysiology of perioperative myocardial infarction. One of the major quantum leaps was this study by Mangano in New England Journal of Medicine in 1990, who studied high-risk patients with Holter monitoring. And he showed that indeed there is a high incidence of perioperative ischemia. But what was very interesting in this study, that most ischemic events were not intraoperative, but rather postoperative. And only the postoperative, or mainly the postoperative ischemic events, were those who correlated with postoperative cardiac complications. But still, he did not reveal much about the pathophysiology of myocardial infarction. And here came Steve Frank at the same year, Steve Frank from Johns Hopkins. In the same year, 1990, he publishes this case report of a patient also monitored by Holter monitoring, undergoes a major vascular surgery, low extremity bypass surgery. During surgery, there is no ischemia. As he is leaving the operating room, there is prolonged ischemia, and the patient dies suddenly after 10, 11 hours. Sorry. And you can see here that at point A, for example, there is an example of the deep ischemia, and at point B, the patient probably got some esmolol, which slowed the heart rate, and there is almost complete disappearance of the ischemia. So we have a prolonged ST depression type ischemia, which led to the patient's death. And in the beginning of the 90s, we were also engaged in perioperative Holter monitoring in vascular surgery patients. And here's a patient that undergoes carotid endarterectomy. She wakes up in the morning with some increase in heart rate and some ST depression. During surgery, there is no significant ischemia. But as the patient wakes up from the operation, there is deep ST depression, the patient develops chest pain, pulmonary edema, and full-blown myocardial infarction. And when we collected 150 patients, we saw something very surprising. We did not see ST elevations. We saw mainly ST depressions, and mainly the prolonged ST depression, more than 4 hours, were those who correlated with postoperative symptomatic myocardial infarctions. And later on, when I was asked to summarize the literature in 2005, I saw that, as a matter of fact, most of the studies with Holter monitoring showed about the same thing. Most of the ischemic events are ST depression rather than ST elevation. This was the situation in the mid-1990s. But then two main things developed in perioperative, not only perioperative, clinical medicine. One is the cardiac troponins. And as you know, today we are diagnosing myocardial infarction only with cardiac troponins. Before we did it with CKMB. And the other thing is the ability to monitor continuous online 12-lead ECG with ST monitoring each one of the leads. And I would like to show you two very interesting patients. One patient, 72 years old, is prepared for carotid endarterectomy, rich history of ischemic heart disease, diabetes mellitus, hypertension, etc. And he comes to the operating room before the anesthesia. We connect him to the continuous 12-lead ECG monitoring, and then the computer starts recording and analyzing the ECG. During the surgery, there is no significant ischemia, but as the patient wakes up, there is deep ST depression that lasts 183 minutes. Okay, we saw the ischemia. The patient was also complaining of chest pain, actually jaw pain. We gave the patient beta blockers and nitroglycerin. The ischemia reverted completely. But when we took troponin, the troponin was 7 times above normal. And on the next morning, when the patient was completely asymptomatic, the ECG returned back to its normal. The troponin was 20 times above normal. So this is the ECG. You can see that the baseline ECG is abnormal, but nevertheless, on top of the abnormality of the baseline ECG, there is deep ST depression in the entire anterior wall, almost 4 millimeters in V4. The second patient is even more interesting, 67 years old, coming for abdominal aortic aneurysmectomy. This was in 2001, before the times we started with the intravascular abdominal aneurysm repairs. So this was an open surgery. The patient did not have a clear history of ischemic heart disease. He was smoking until 12 years ago, and he was a little obese, and he had the shortness of breath on exertion. So in these high-risk patients, we normally send these patients for non-invasive cardiac stress testing. And this is a thallium diapyridamole of this patient, and you can see here reversible ischemia in almost the entire anterior wall. Okay, you can see it here, you can see it also here. The echocardiogram was normal except for moderate mitral insufficiency. So obviously, this patient goes for coronary angiography. In coronary angiography, left-sided angiogram, circumflex is very nice, but there is no LED. Injection to the right coronary, there is a retrograde filling of the LED. Okay, so the patient had total ostial occlusion of the LED. And that was the reason for the ischemia on thallium. So here was a debate between the cardiologist and themselves, with us and the cardiac surgeon, what to do with the patient. But this was, I remind you, 2 years after Don Poldermans published his study in the New England Journal of Medicine, showing that if you take exactly those kind of patients and you give them bisoprolol for 1 month before the operation until 1 month after the operation, you reduce by 91% the incidence of myocardial infarction and cardiac death. So the decision was to give this patient bisoprolol for 1 month before the operation, and not do cardiac surgery limited to the LED. And here's the patient. He arrives to the operating room like the previous patient. We start recording the ECG. During surgery, there was no significant ischemic event. But as we wake up the patient, there is ST depression, deep ST depression, with increase in heart rate from about 67 during surgery to 92. So there was a breakthrough in heart rate. We saw this ischemia. We immediately gave him more beta blockers. You can see the ischemia in the entire anterior wall, ST depression, of course. And the ischemia regressed. So we said, this patient is going to show us that he knows how to make problems. So we took the patient to the intensive care unit with esmolol drip. Despite the esmolol drip and overdosing even the esmolol, you can see here that the heart rate, it was very difficult to control the heart rate. And indeed, about 6 hours, 5-6 hours later, this patient became unstable with very deep ST depressions in the entire anterior wall. Almost 4 millimeters ST depression with a heart rate of only 92. So eventually, we were scared, but eventually we were able to control the ischemia, and the ECG reverted completely to his normal. In the next morning, the troponin was still, this time it was troponin T, the troponin was still low, but in about 12 hours, the troponin went up to 156 and then 168, and it took another 5-6 days until troponin went down to normal. So at this point, I usually ask the students, do you think that the patient had myocardial infarction? I think the patient had myocardial infarction because he had troponin, increase and decrease of troponin, and he had ischemia on the ECG, 12-lead ECG, and he was also symptomatic, and he also had, on echo, there was a regional dysfunction of the left ventricle. But where's the plaque rupture? I think you would agree with me that there was no plaque rupture. Even the cardiologists didn't think that there was plaque rupture, and they did not even catheterize the patient. This case is really very rare. Why is it rare? First of all, it's rare to see a patient with only single coronary disease, total occlusion of the LED. But it is also rare with the complete cardiac workup that we had on this patient before, during, and after the operation. Okay, we had the thallium scan, we had the echo, we had the continuous 12-lead ECG, we had the troponin measurements, and we had coronary angiography, we had everything. Nowadays, we don't have, in most of the places that I know, including in our hospital, we don't have this complete workup on the patients. But fortunately, look at this study that was published in 1996 from the Cleveland Clinic. What did they do in Cleveland Clinic? This is a retrospective study. In the 1980s, and also 1990, they used to do coronary catheterization to all patients who are candidates for vascular surgery. And if the patients had significant coronary artery disease, like left main, triple vessel disease, etc., they would send them for coronary bypass before the days of PCI. Before the days of PCI, they would send them to coronary bypass before the vascular surgery. So here you have 1,500 patients who had vascular surgery without coronary bypass, and they found 21 patients who had postoperative myocardial infarction or cardiac death. And they match controlled them with 42 patients without postoperative cardiac events. And look at the preoperative coronary angiogram of those patients. 81% of the index patients had total occlusion of a coronary artery with collaterals, as if I gave them my patient, exactly the same patient. Oops, sorry. And in the control, only 29%. If you take every one of the parameters of the number of coronary arteries, significantly diseased coronary arteries, and the amount of stenosis in the coronary arteries, these patients are much sicker patients than this, which is not surprising. But if you look at this, more than 17%, 2.1 compared to 0.7. But if you remember the slide that I showed you in the beginning of the lecture, that most of myocardial infarction are actually occurring with plaques that are less than 50%. So there is some contradiction here. So what were the other insights from our study, continuous valve ECG study? All ischemic events were correlated with significant, I think they were the result of increase in heart rate, tachycardia. Nevertheless, if there was troponin elevation or not, and the longer the ischemia, the higher the troponin level, the higher the likelihood of troponin elevation, and most of the ischemic events started very early after surgery, and definitely within the first 24 hours after the operation. So here's come the story of the troponin. Okay, when we collected 447 vascular surgery patients, and we were measuring troponin on the first 3 days after surgery, the higher the troponin level, the higher the cutoff of troponin elevation, the worse is the 5-year survival. Okay? And this was in 2003. In 2005, Lemanach was publishing this in anesthesiology, 1,100 patients undergoing abdominal aortic aneurysmectomy. He was measuring troponin every 6 hours after the operation, and the higher the troponin, if it crossed the cutoff level of myocardial infarction, definitely there was higher in-hospital mortality, but even lower increases in troponin, what they call myocardial damage, were associated with higher in-hospital mortality. And 90% of all troponins started to increase already within the first 24 hours after surgery. It took another almost 10 years for P.J. Devereux to collect these 15,000 patients worldwide, and he showed that the higher the troponin level in hospital, he was using exactly the same methodology that I was using. The first 3 days after surgery, troponin elevation. And the higher the troponin, the higher the in-hospital mortality, or the higher the 30-day mortality. And Scott Beatty, who's just he's our chair, did exactly the same study, but with retrospective analysis, also a huge number of patients. The higher the troponin after surgery, the higher is the mortality. And here's another study from Holland, Judith Van Wees, 2,000 patients. The higher the troponin, the higher the 30-day mortality. So what is the pathophysiology? In 2002, I was asked by Martin London to write a review. He knew that I am talking about that a lot, to explain what is my view about the pathophysiology of perioperative myocardial infarction. So I decided to lay out my idea, and I said, look, there must be two different types of myocardial infarction. One is plaque rupture type myocardial infarction, and the higher incidence is about 50%, 50 to 70%. But in the perioperative setting, the more coronary artery disease you have, and even one coronary artery with total occlusion can still cause myocardial infarction. Okay? It took another 4 years, and all the major cardiology associations, came out with this new definition, or they call it universal definition of myocardial infarction. And type 1 is the spontaneous myocardial infarction related to ischemia due to primary coronary events such as plaque erosion, rupture, fissuring, and dissection. This is the old definition of myocardial infarction, type 1. But they added type 2, myocardial infarction secondary to ischemia due to imbalance between oxygen supply and demand, coronary spasm, anemia, hypotension. I was really happy at that time. But I told them, guys, you forgot the main reason for type 2 myocardial infarction, which is prolonged tachycardia. And I must stress here, it's not really tachycardia. What's defined in the books as tachycardia is heart rate above 100. It should not be 100. As I showed you, patients with a heart who are normally with a heart rate of 60 to 70, if their heart rate increases after surgery to 92, it is a 50% increase in the heart rate. It is enough for them and there is a prolonged increase in heart rate. It is enough for them to cause ischemia and type 2 myocardial infarction. So later on, with Scott Beatty and two of the prominent leaders of the universal definition, Ellen Yaffe and Joe Alpert, we wrote this concept of perioperative myocardial infarction, which states that indeed there are two types of myocardial infarction. Type 1 is indeed the acute coronary syndrome. But fortunately, this is quite rare. This is quite rare. At least we don't see ST elevation type myocardial infarction so often. It can happen in a patient who has a coronary stent, especially if it's a fresh coronary stent, and we need to stop the dual antiplatelet therapy. Of course, this patient can develop acute coronary thrombosis on top of this coronary stent, but this is type 1 myocardial infarction. The other type of myocardial infarction is type 2. And type 2, the main reason is heart rate. As you know, I don't have to explain to anesthesiologists why heart rate is so important in causing ischemia, because it decreases, it not only increases myocardial demand, it also significantly, and I think even more than that, more than increasing demand, it decreases significantly the myocardial oxygen supply. And of course, other reasons are hypotension, changes in myocardial wall stress, anemia, hypoxemia. All of them play significant part in the pathophysiology. So you can see here some examples. In 2016, this is a reanalysis of the VISION trial, preoperative heart rate. The higher the preoperative heart rate, the higher likelihood of myocardial infarction and mortality. And actually, slow heart rate prevents or protects from myocardial infarction. And then hypotension. There is a study from last year. The lower the mean blood pressure, the higher the odds ratio of mortality. And again, reanalysis of the VISION. Not only increase in heart rate, significantly increase in myocardial infarction and mortality, but also decrease in blood pressure, systolic blood pressure below 100 significantly. But not only those parameters themselves, but also the duration of increase in heart rate and decrease in blood pressure. And this is an interesting study also from the VISION trial. 955 patients from the VISION trial had preoperative CT coronary angiography. And patients, you can see here that the patients with extensive obstruction of the coronary arteries had the worst survival. Patients with obstruction but not so extensive, also had the reduced survival. Non-obstruction were almost like normal. But then they did another analysis of the same group of patients, 955 patients, and they added hypotension. So you can see here obstructive or extensively obstructed coronary disease, in addition to hypotension, less than 90 systolic blood pressure for more than 10 minutes, which is almost nothing. And hypotension alone was also predictor of mortality. And if a patient had either hypotension or significant obstruction, also increased mortality in comparison with no. And this is our next speaker, Peter Nagel group, a study from last year. They did something really interesting. They took 250,000 patients almost who had the surgery in Washington University, and were declared after surgery as having acute coronary syndrome. So this was 0.07% of the patients. And they looked back at the coronary angiogram. They were defined as ACS, and that's why they had coronary angiography. 80% were non-STEMI, 14% were STEMI, and another 5% were defined as angina pectoris. They looked better at the coronary angiogram, and they defined almost 3/4 of them as type 2, 1/4 as type 1, and the stent thrombosis in 2%. And the prognosis was worse in type 2 myocardial infarction compared to type 1 myocardial infarction. So you cannot underestimate type 2 myocardial infarction. And this is almost a similar study published 2 years ago in JACC from Cleveland Clinic. They took almost 500,000 patients. 1,000 of them had troponin elevation 5 times above normal. And they did coronary angiography to all those patients. 3.6% of them had STEMI, 22% of them had non-STEMI, okay? And they underwent PCI. Most of the other patients all the other patients had coronary angiography without intervention. So the outcome of the patients was worse in patients who had peak troponin, higher peak troponin, in patients who had bleeding, and in patients who had vascular surgery. You can see it also here. The problem is that we are still left with a big puzzle. We still don't know. We still don't know a big part of the conundrum. There is a huge percentage of patients with silent myocardial injury, and let's define again what is myocardial injury. Don Poldermans, P.J. Devereaux calls this means myocardial injury in non-cardiac surgery. I prefer to simply call it myocardial injury, as they defined it in the universal definition of myocardial infarction. This is a rise and fall in troponin, okay? Acute rise and fall in troponin, above the cutoff level of 99%. If there is symptomatology, in addition to the increase and fall in troponin, this is can already be called myocardial infarction. Whether it's symptomatology or changes in ECG or another proof of myocardial infarction like imaging, etc. So this is I'm taking you back to this study, our study in 2003. We already then showed that if you are taking the lowest cutoff level of troponin, 0.03, as we defined that in those days, almost 25%, almost a quarter of our patients had such a high increase in troponin. But only 17% of those patients were symptomatic or had any symptom or attributable to myocardial infarction. And also the incidence of ischemia was relatively low. Only if you go to higher levels of troponin, then you have a lower number of patients with the cutoff for myocardial infarction, but still more than 50% of the patients are asymptomatic. The incidence of silent ischemia is higher. And this is a study from last year, very interesting study from Basel. They took 2018 patients, and they took troponin before and also after surgery. And if the patient had an increase, a significant increase in troponin, they called it myocardial injury. 16% had the myocardial injury. Only 18% of those had any symptoms. So if they had symptoms or ECG changes, they would call it cardiac postoperative myocardial injury. And if they had another causes, no symptoms related to their heart, but sepsis, bleeding, pulmonary embolus, or something like that, they would call it extracardiac postoperative myocardial injury. So first of all, not surprising, those with PMI, postoperative myocardial injury, had the worst survival. But the worst survival was those who had extracardiac PMI. Not those who had cardiac symptoms, but rather those who had extracardiac causes of PMI. There was no significant difference between those who had symptomatology and those who did not have symptomatology. Not in the 30-day and not significant even in 1 year. But here they added something more interesting. They took the preoperative troponin and added it to the postoperative troponin. And now the patients who had preoperative troponin elevation and further increase in troponin, they had the worst outcome, okay? 30-day and 1-year outcome. The patients without preoperative, without postoperative had this outcome, and the patients in between are those who had either preoperative or postoperative troponin elevation. And this is our next speaker again, Peter Nagel. He looked at preoperative troponins. And you can see here that patients who had slight elevation, even slight elevation of troponin above 0.014, okay, above the cutoff level of normal, they already had worse postoperative outcome. And this is my almost last slide. Another sub-analysis of the VISION trial. P.J. Devereaux showed that troponin is mainly predictive of outcome if the eGFR is above 30. In patients with eGFR below 30, the troponin is not independently predictive. So what are my conclusions? First of all, postoperative myocardial infarction is mainly non-ST elevation and type 2 myocardial infarction. These are, we still see, but we rarely see ST elevation type myocardial infarction after surgery. The predominant factors are high-grade stable coronary artery disease, prolonged stress-induced ischemia, tachycardia, and hypotension. STEMI is rare, as I said. And about injury, silent postoperative injury, myocardial injury, is at least 10 times more common than overt myocardial infarction. Nevertheless, short-term and long-term outcome correlates with peak troponin level, regardless if troponin elevation is silent or overt. And patients with elevated preoperative troponin level and additional troponin elevation after surgery are at the highest risk. That's it. Thank you.